Hi, my name is Melissa Younger. It is April 20th, 2021. I am going over Unit 2 Case Study Connections. I chose cases 2 and 4, and I'm going to begin by reading case 2. A 16-year-old female is recently diagnosed with a deficiency of muscle glycogen phosphorylase. Her and her family are concerned and ask the following questions. Based on what you know about skeletal muscle glycogenolysis and muscle metabolism, please respond to each question. The patient states, I'm not sure I understand the issue. Can you explain how muscle glycogen is used normally during exercise? My answer is the body uses hormones and enzymes to regulate metabolic processes. One of these processes is the maintenance of sufficient glucose to use as an energy source during physical activity. For example, during exercise, a hormone called epinephrine is secreted, which in turn stimulates an entire metabolic pathway that will break down glycogen as a source of energy your body can use during exercise. With glycogen storage diseases, the enzyme required to break down glycogen is impaired, making exercise tolerance difficult for those affected by the skeletal muscle variant of the disease. Question number 2. Patient states, I really like to take long walks. Will I be able to do this with my friends? Answer, yes, you will be able to continue to take long walks with your friends. In fact, there is an abundance of research detailing the many benefits of prescribed exercises to improve symptoms of the disease and improve quality of life for those living with skeletal glycogen storage disease or McArdle's disease. It is important to pay attention to how your body is feeling, because if you're having excessive amounts of pain and muscle cramping, tachycardia, then you must take rest, because otherwise you'll be at risk of having rhabdomyolysis, acute kidney injury, and things like that. So in order to prevent those things, you have to rest frequently so you don't end up injuring yourself. And after about 10 minutes, your body will begin to rely on other metabolic pathways as alternate sources of energy. Those compensatory mechanisms will allow you to continue to participate in long walks. So although the patient will not be able to tap into her skeletal muscle glycogen stores, the body relies on other areas like the liver or the adipose tissue to get into those other glycogen stores. Let's see, as a result of this deficiency, will I need to get up in the middle of the night to and eat to maintain my blood glucose levels? In my opinion, no. Your symptoms are most consistent with GSD or glycogen storage disease type 5 or McArdle's disease. This GSD specifically affects the enzyme myophosphorylase. This will produce symptoms associated with exercise intolerance, not hypoglycemia. So this is where my answer kind of gets a little bit long-winded, but I'll try to summarize it here at the end. Since the liver is responsible for the regulation of serum blood glucose levels or red blood cells and glucose to be used by the brain, a different type of GSD that affect hepatic glycogen phosphorylase will result in hypoglycemia. Basically telling the patient that her type of GSD is one that mainly affects, is going to be her skeletal muscles and going to be an issue of exercise intolerance, rhabdomyolysis, acute kidney injury, things like that. It's going to affect the way she performs physical activity. Hypoglycemia, that is going to be a different type of GSD. That's going to be one that mainly affects glycogen storages in the liver, since the liver is going to be responsible for maintaining blood serum glucose levels. So no, she's not going to have to wake up and worry about eating in the middle of the night to maintain her blood sugar. Question number 4. Do I need to worry about producing excessive lactate during exercise, during intense anaerobic exercise? No. You do not have to worry about excessive lactate during anaerobic exercise. In fact, your lactate levels will be very low after exercise. Individuals with your type of GSD do not produce lactic acid for anaerobic energy consumption during exercise. So anybody who has a GSD, has McArdle's disease, after exercise, typically their lactate levels are actually going to be quite low. The rest of us, who don't have the disease, if you check after exercise, we're going to be high, but not someone who's affected by McArdle's disease. It's going to be low. Okay. Moving on to case 4, a previously healthy 2-month-old female. She's coming in to see the doctor for jittery spells after breastfeeding. Her mom reports that she hasn't given the baby anything else since birth. She's only relied on breast milk for her diet. The baby has just recently started to sleep more than 2 hours between feedings, which is also coincidentally when the symptoms started. Laboratory results are consistent with hypoglycemia, but otherwise unremarkable. Epinephrine was administered. There's no increase in blood glucose levels. However, there is an increase in blood lactate. Which of the following is the most likely diagnosis of this patient? So the first question is, does the patient have hereditary fructose intolerance? So no, the patient does not have hereditary fructose intolerance because per the mother's report, the infant has only had breast milk her entire life. So we know that breast milk is composed of lactose, which is a disaccharide of galactose and glucose. Being that there's no fructose in breast milk, this can't be the correct diagnosis for this patient. Galactosemia. So breast milk is made up mostly of lactose, which is a disaccharide of galactose and glucose. So when ingested, galactose is absorbed by the intestinal cells and phosphorylated to galactose 1-phosphate. In order for the phosphorylated galactose to be stored as glycogen or become an activated sugar, the enzyme galactose 1-phosphate uridyl transferase, or aka GALT, is needed to do that. Symptoms can include, for the patient, irritability, poor feeding effort, vomiting, jaundice, or cataracts in the eyes. So, I mean, honestly, this could be a differential diagnosis. However, I don't think that these symptoms fully explain what's going on with our patient, with the infant. Although milk is the only source of nutrition, I believe the symptoms would have appeared before 2 months of age. So if the patient had galactosemia, I believe that the patient would have had symptoms before 2 months of age. Also, in addition to that, infants born in the United States in the hospital, this is a metabolic disease that they test for all of them. So it makes it even less likely that the patient would have something like this. The next potential diagnosis is glucose 6-phosphate dehydrogenase deficiency. And I said no. Although the infant does have hepatomegaly, she is not jaundiced and shows no signs of hemolytic anemia, which she would have if she had G6PD deficiency, which would have been reflected in the infant's blood work. Her complete cell blood count would have reflected the hemolytic anemia, and it did not. So also, we have a female infant, and this particular deficiency affects almost exclusively males. So not impossible, but just makes it even less likely that the patient would have something like that, would have that. Glycogen storage disease. Yes, I said yes. The patient does have a glycogen storage disease, and it would explain the symptoms that the patient is having. So the specific type of glycogen storage disease is called von Gierke's disease. In the liver cell, glucose, it can pass freely into the liver cell. However, in order to keep the glucose confined to the cell, it's phosphorylated into glucose 6-phosphate and trapped inside the cytosol of the cell. From there, it is transported by the G6PT1 into the endoplasmic reticulum, into the ER. In von Gierke's, there's a deficiency in glucose 6-phosphatase, leading to the accumulation of both glucose 6-phosphatase and glycogen. The accumulation of glycogen in the liver would explain the hepatomegaly that our infant has, and the inability to convert glycogen to glucose during fasted states, aka while the baby is sleeping, would explain the hypoglycemia when the infant sleeps more than 2 hours at a time. Lactic acidemia is also a hallmark of this disease process. The administration of epinephrine and high lactate is a rule out for McArdle's disease. That was kind of a side note, because if the patient would have had McArdle's disease and you gave them epinephrine and their lactate would have increased, you would know. Okay, I kind of said that backwards, but yes, you would know that the patient does not have McArdle's disease because they gave the patient epi and then their lactate was high. And McArdle's disease, it would have remained low. That's it. Again, that is, have all my references? Yes. Again, this was Unit 2, Case Study Connections, cases 2 and 4. And I am Melissa Younger. Thank you.